He completed both his internship and residency in internal medicine at the University of Pennsylvania and completed fellowship in infectious disease at Columbia University Medical Center here in New York City. Dr. Winetsky joined SUNY Downstate in May of 2022 as a clinical assistant professor of medicine and infectious diseases. Based in the STAR program, Dr. Winetsky specializes in providing HIV primary care and serves as a clinical lead for status-neutral LGBTQ+ services. Prior to joining STAR, he conducted research on several topics relevant to global health and immigration, including the epidemiology of tuberculosis in the prison system of Kazakhstan and the relative cost effectiveness of providing antiretroviral therapy to HIV-positive labor migrants in Botswana. He also served as the site medical director for the East Jersey State Prison from 2015 to 2017, and has conducted forensic medical and psychological evaluations for asylum seekers as a volunteer with Physicians for Human Rights, focusing on individuals held in immigration detention. Quite a bio, and I cannot wait to hear what he's going to share with us today. Thanks for coming.
Okay, thank you so much, Dr. Benson, for that introduction. It's nice to meet you, and I really appreciate those kind words. And I want to thank Dr. Smith for organizing this and for inviting me, and also for that introduction about social determinants of health, because I think that's wonderful framing, and I think it's very central to the work we do in STAR and to sort of what I do from day to day as an ID specialist. All right. So I have a lot of topic, and a lot of stuff to cover, and I would easily spend the whole time on one slide probably if I was left to my own devices. So I'm going to try and dive right in and move quickly. So I have no conflicts of interest to disclose. I'm going to talk first a little bit about just in general infectious disease epidemiology and transnational migration patterns and how we think about that as infectious disease specialists. I'm going to talk about HIV and AIDS, tuberculosis, and malaria, because these are major considerations that are going to be common enough that we need to make sure that we're thinking about it. Of course, discussing other febrile syndromes. I'm going to talk a little bit about cutaneous infections that might not be so obvious, the sort of not the run-of-the-mill cellulitis that we're used to. And then a little bit about chronic parasitic diseases, and then just sort of general screening and immunizations to prevent infections. For the diagnosis of infectious diseases, and this is true of everything, but I think especially infectious diseases, the pretest probability of any particular syndrome or disease is dominated by the epidemiology. As an example of what I mean by this, we think of COVID. If you have a 65-year-old male who's presenting with cough and a fever in New York City, in March of 2019, the probability that it was caused by SARS-CoV-2 was essentially 0. But in March 2020, it was about 75%. So the pretest probability can go up and down by several orders of magnitude, depending on what's happening within the community and what the likelihood of exposure to a certain infectious pathogen. And this is true not only of acute communicable infections like viral respiratory tract infections, but also of chronic infections, especially if there's a latent state and your pretest probability is essentially only epidemiology, not based on, with no clinical syndrome to help shape your pretest probability. So in order to know what infection a person in front of you has, you must know where they have been. So when we think about potential exposures associated with migration, and this is sort of lumping together several categories, as you pointed out, Dr. Smith, of immigration and migration, but including refugees and asylum seekers. But broadly speaking, there's sort of three phases we can think of. There's pre-migration, the country of origin. There's the places that a person spends time during migration as they're on their way here, and I'm going to talk a little bit more about that. And then there's the things that have happened since arriving. And so you have to think about three different epidemiologies when you're, particularly with someone who has recently arrived, you have to think about three different geographic epidemiologic exposure potential. And then think about what the person has done in those places or where they have been, certain elements of that exposure. You want to think about how much time they spent in each place, and how much time has elapsed since, and which is particularly relevant for incubation periods. You need to think about the environmental conditions in the area that they were, urban versus rural, whether the climate of the place that they were. And as an example of this, individuals may be injuries that are sustained along the way may be exposed to ambient soil or water, which can increase the likelihood of certain atypical organisms, depending on where they are. You have to think about the individual's behavior, especially behaviors that are stigmatized, that might have led the person to led the person to flee their home country. Those stigmatized behaviors may be epidemiologically relevant, and you have to think about safety-seeking behaviors, and I mean this broadly. So this might be how someone copes from trauma, from psychological trauma. So people may increase their use of substances to cope with the stress of the journey, the stress of what's happened to them, to cope with trauma-related, PTSD symptoms. They might have to engage in survival sex as a way of staying safe, attaching themselves to a predatory individual. And you have to think about external forces. As I mentioned, physical, psychological trauma, injury, incidental injuries, fear of being caught, all these can, in several ways, predispose to certain infections. And of course, resources. A classic example of this would be sleeping outside makes someone more likely to be exposed to arthropod bites. They're unlikely to have insecticide-treated bed nets on the way here. And of course, biological host factors are important. What is their underlying host status? Do they, unfortunately, persecution and the challenges that lead people to flee their home countries do not, or move here, whether it's fleeing persecution or economic depression, it doesn't only affect people who have normal, healthy immune systems. So in the last few decades, migration routes from South America, Central and South America to the United States have become very well established. And I think this is this is talked about a lot in the media. Trafficking organizations have become highly sophisticated and administratively complex, using social media to market their services, to stimulate demand and mitigate perceptions of risk. And these organizations act to some extent like modern corporations. They are collecting information and responding to data about enforcement actions to avoid capture and to adapt their methods in order to avoid capture. The result is that there's this large dynamic flow of some of the world's most vulnerable individuals through a very wide geography, a sort of long path from South America to the United States that passes through a wide variety of ecosystems, stopping for various lengths of time in different population centers along the way. The route involves crossing the notoriously dangerous Darien Gap, which I think people hear about, but we have to think not just of that environment. So while that is one sort of rainforested area, people often pass through the deserts of Mexico as well. And you have to, if you look at these maps, you'll note that there are these wings, these lines going through the sea. So often it really is by hook or by crook. It may involve different modes of transportation. People may be taking boats at one point, trains at another point, walking on foot. It really can be a wide array of exposures. And each individual has to understand, and you have to understand what happened to each individual. Of course, the threat of physical and sexual violence is present throughout this journey because these are extra-legal trafficking organizations. So in talking about migration, we can't ignore the global AIDS pandemic, the pandemic of HIV and AIDS. One thing that I'm not sure how widely understood this is, but there has actually been a fair amount of progress in the global fight against HIV and AIDS. You'll see here on the right that incidence, newly acquired HIV is, and deaths due to HIV have been declining for now a decade and a half. And so, but it still remains prevalent in much of the world. You look at this pie chart, and really it's kind of spread quite a lot. The sort of red countries are Africa, but there's Eastern Europe, the Caribbean, Asia, Pacific. Really, HIV is prevalent everywhere. And so there's no one in which we shouldn't think about this as an exposure. HIV-related stigma is a global phenomenon as well. But the manifestations vary depending on local socio-political and cultural context. HIV-related stigma is often compounded by stigma, discrimination, and persecution related to minority group status. So an individual, this is sort of a two-way relationship in which stigmatized communities are predisposed disproportionately to HIV and vice versa, and then on top of that end up having HIV-related stigma to contend with in addition to HIV itself. HIV-related stigma can impair access to risk reduction measures. So, people may be afraid to seek safety, seek professional help to maintain safety. Because they're afraid of their HIV status being disclosed. That may reduce uptake of testing and treatment, as people don't want to have to deal with the stigma of finding out about their HIV status or of being seen in a clinic. It's a thing I often hear from my patients, that they never sought treatment in their home country because they didn't feel that confidentiality was assured. HIV-related stigma may predispose to psychiatric and psychological comorbidities, even without more serious psychiatric or psychological problems. Dealing with an HIV diagnosis involves a certain amount of a certain amount of distress and requires coping, but it can often lead to more severe problems as well. And then HIV-related stigma can impair trust in healthcare providers and other authority figures. And I think, one of the best examples of HIV-related stigma I can think of from my own experience, I once did an asylum evaluation for an individual who was from Nigeria and had been beaten several times, throughout his life, had been attacked physically. The main purpose of my evaluation was to document the scars on his body and demonstrate that they were consistent with his description of events. But another element that the lawyers asked me to comment upon was the fact that he had denied his HIV status to immigration officers on more than one occasion, and that this led to this could be a legal problem for him because it makes his credibility, it puts in question his credibility about what happened. And so, one thing that I had to convey was the way in which, in his country, he was, HIV-related stigma, it turns out the extent of internalized stigma relates to the amount of stigma and the cultural context and the legal context. And in Nigeria, homosexuality can lead to a prison sentence of 14 years. And so this had led to, to a certain extent, a form of psychological denial about his sexuality and about his HIV status, and conveying that was helpful in his asylum case. That the reason he said he was, was HIV negative was not that he was lying, but that he was in psychological denial related to HIV stigma. Some important points about HIV and AIDS in the clinical context in which we are seeing patients. So care seeking in the emergency department provides a unique opportunity for detection and linkage to care for a highly vulnerable population. As with any patient living with HIV and AIDS, it is critically important to assess the degree of virologic control, as this drastically changes the approach to essentially any complaint. With someone who is well-controlled HIV, that has been well-controlled for 6 months or more, basically all opportunistic infections are down at the bottom of your differential. And you're essentially treating HIV like you would treat hypertension, in a non-cardiovascular complaint. And it's not always easy to figure this out when you're first meeting someone and you don't have, and if they're not in our system where you can look back at their last viral load. But a careful history of prior HIV-related illness and antiretroviral treatment can help you sort this out in a pretty quick manner. So, a key question I always ask is, what was happening when you were first tested positive for HIV? I mean, most people, if you ask them if they've had an opportunistic infection, they're not going to know what you mean by that. But if you ask, were you sick or was it like asymptomatic screening? That gets right away, gives you a sense of where they were when they, if and when they started treatment, when they were diagnosed, did they have a low enough CD4 count that they developed an opportunistic infection? If they really were found positive with asymptomatic screening, that means they're unlikely to have advanced AIDS at the moment, less likely at least. And then ask about prior antiretroviral access. Most countries in the world, you can get antiretrovirals. As I mentioned, HIV-related stigma and economic barriers may certainly be at play, but it's not uncommon for people to have their HIV. In most parts of the world, there's huge efforts to treat HIV in primary care clinics and small community, in rural communities even. So asking about prior HIV control. Now, antiretroviral access often is interrupted during the migration process, but not always. And so, people may have, I've had patients who were able to get had their HIV medications interrupted, but were able to get some antiretrovirals while they were in Mexico for a period of time. And so basically were on antiretrovirals when they got here. So asking about HIV, if someone asking about their access through the, with a few questions, you can really complete risk stratify. Is this someone where a headache is just a headache, or is this a headache that could be cryptococcal meningitis? And really, it's about virologic control, and that's a huge branching point at the very top of your sort of algorithm for a diagnosis. Another sort of quick and dirty way to assess someone's immunologic status is to look at their absolute lymphocyte count on the differential. There's pretty good negative predictive value that if the absolute lymphocyte is greater than 1,500, the patient is very unlikely to have an absolute CD4 count less than 200. Although, it's obviously not as good as an actual CD4 count. That takes weeks. So, that's a good, using these sort of quick questions, we can arrive at an understanding of what's going on pretty quickly. So for a patient with well-controlled, as I said, well-controlled HIV, you don't need to worry so much about, the broad differential of things of bad things that could be causing their headache or their cough. Now, immediate initiation of antiretroviral therapy has become the standard of care and should be the goal for any new diagnosis. And by that, I mean prescription at the same day. In accordance with the Ryan White Care Act of 1990, each state receives federal funds to administer an AIDS drug assistance program. That's called an ADAP. ADAP was initially designed to fill the eligibility gap between Medicaid and private insurance, but has become largely the fail-safe for undocumented immigrants because that gap was essentially eliminated by the Affordable Care Act. So ADAP is basically a provider of HIV care and antiretroviral therapy and many associated medications for undocumented immigrants. It's designed to allow a rapid start. So if you have a new diagnosis, you can you can call Stephen, our focus care coordinator. You can, if it's after hours, you can email starlinkage@downstate.edu, and you can, if need be, you can bring the patient over or just have them come over to Star, and we can get them started on ADAP. We have case managers that are always there, and that this is what they do day in, day out. They know how to get it done. And just on this topic, of course, any immigrant, everyone should have HIV and STI screening offered. But because, as I mentioned, sexual violence is an unfortunate reality for many people, a threat for the through the migration pathway that STI screening should be offered. We shouldn't fail to forget. Now, tuberculosis. Vast majority of cases of active TB in the United States are among adults who are foreign-born. TB incidence can vary widely. And coming back to this concept of the pre-test probability, where you come from, more than any other clinical feature almost, dominates the pre-test probability of any symptom, but especially pulmonary symptoms being tuberculosis. So as an example of how this can scale up and down, the United States, our incidence for TB is 2.9 cases per 100,000 person years. Mexico is 10 times that, at 28 cases per 100,000 person years. Venezuela is a little under 2 times the incidence of Mexico, and we have rising flows of immigration from Venezuela. Haiti is yet another more than 3 times the incidence of Venezuela. And just to sort of see the scale of things, this is the country with the highest documented incidence in the world, Central African Republic, 540 cases per 100,000 person years. So as you can see, this is more than 100, someone from Central African Republic who has a cough is more than 100 times as likely as someone who spent their whole life in the United States to have tuberculosis as the cause of that cough. So really that, asking a patient where they're from, and I beat my ID fellows with this, over the head with this, like asking where they were born is very important. And just on this topic, other canonical risk factors, often in medical schools, it's taught, the risk factors are foreign-born status, incarceration, HIV, having, been in a shelter. These risk factors are not equal. These other sort of canonical TB risk factors have an odds ratio more like 2 to 3, not 10 or 40 or more. Here's just what TB incidence looks like around the globe. And so, you can see there's Central African Republic, but there are other places that really are hyper-endemic. That's important to keep in mind. Now, the risk of active TB is highest in the first year of acquisition. So if there's a known exposure or known seroconversion, then following that first year, and so that's why it's an important consideration for recent migrants, who often may be spending time in camp, densely populated encampments or immigration detention, where they're more likely to be exposed. But the risk then, as the individual enters the latent state, then the risk steadily rises later on in life. So this is actually most cases of active TB in the United States are from people who were exposed in childhood and then moved to the United States sometime in early adulthood or later in childhood. And then as they age and T cell senescence takes in, the TB reactivates. Some common pitfalls: quantiferin is not a test of active TB. It can convert to negative due to anergy during active TB disease. It is about 80% sensitive. That is not sufficient, and the specificity is like near zero, because the vast majority of people who are PPD positive or quantiferin positive do not have active TB at the moment. They just have latent TB. So it is really a test for latent TB. Another pitfall on this question is BCG is not the explanation for PPD positivity in the vast majority of cases. So when you get the BCG vaccine, matters a little bit for how long the PPD positivity lasts. So if it's given at birth, it only lasts into like a few years into childhood, and then people seroconvert back to negative. If BCG is given at school age, the quantiferin positivity wanes in adolescence and early adulthood. TB is more likely to present with atypical symptoms in patients with uncontrolled AIDS, so don't look for the Ghosn complex if someone has AIDS. So malaria. Malaria is among the most common causes of fever in returned travelers from endemic areas of Africa. And P. falciparum, it has the shortest incubation period and is most likely to progress to severe disease. So if you have a patient who just recently returned from sub-Saharan Africa or migrated from sub-Saharan Africa and they have fever, you want to use a rapid antigen test for P. falciparum. In the Central American and Caribbean context, we're more likely to see P. malaria, P. ovale, and P. vivax, which have longer incubation periods, and because of the dormant hypnozoites in ovale and vivax, can actually present much later, up to a year later. Long-time immigrants returning to their homeland are actually at highest risk due to loss of immunity. So someone who was born in a malaria endemic country and then returns there to see family is actually the highest risk because their immunity has waned, but they're still going to a region where their exposure risk is much greater than someone who's staying in a hotel in a capital city. Dengue is the most common cause of fever in travelers from Central and South America and the Caribbean and Asia. So, you know, it's malaria. While malaria is still on the differential, dengue is a little bit more likely. Mainstay of dengue management is really a triage function and supportive care. Patients without warning signs actually are usually managed as outpatients in dengue endemic areas. The warning signs to be aware of are abdominal pain and tenderness, persistent vomiting, clinical fluid accumulation, meaning like effusions, ascites, edema, mucosal bleeding, lethargy and restlessness, hepatomegaly, and then this pattern of rising hemoglobin in combination with a rapid drop in platelets. So patients in the febrile phase who are more likely to progress to critical illness have these warning signs. Chikungunya and Zika mimic dengue and actually followed its spread across the globe. There's interesting epidemiology about how these viruses have often start in the sort of in Africa, in like West and East Africa and the tropical regions, and then have spread east across the globe, first to Southeast Asia, and then make their way here. That pattern happened with those three: chikungunya, Zika, and dengue. Urupush virus is a new one that is joined as of earlier this summer. Not much we need to know about it necessarily, but just it's a fun thing to try and say out loud. And it actually did not, or it seems to have originated in South America. Typhoid fever, especially in South and Southeast Asia. Secondary syphilis, mpox. So sexual exposure happens, you know, even if you are from a very interesting place. Leptospirosis is another risk, another thing that could cause a febrile syndrome. So looking for LFT abnormalities, especially T-billy. Rickettsial diseases, especially the typhus group. Bartonella quintana, so trench fever. The typhus group of rickettsial diseases are not spread by ticks, but by lice. So that's partly why recent migrants and refugees may be at risk for that. Hepatitis A, influenza, COVID, and RSV, of course. So cutaneous infections, a little bit about this, some bad rashes that might occur. Cutaneous leishmaniasis is a relatively common cause of non-healing ulcers in Central and South America. Lesions typically have raised borders with depressed ulcerated center and are usually painless, but can become secondarily infected, and then they become tender. Biopsy for histopathology and PCR are necessary for the diagnosis, but the differential for a lesion like this is very broad, including invasive fungal infections that like chromoblastomycosis, histo, and cocci, which are all often which are potential exposures. Non-tuberculous mycobacteria, so Buruli ulcer, M. marinum, for example, if someone has a wound, if it started with a wound that happened on a boat, that's more likely to be M. marinum, Mycobacterium marinum. And of course, you know, you want to make sure it's not squamous cell carcinoma. So you would want to make sure that there are, if you are biopsying it, make sure that you order fungal and AFB cultures as well as standard bacterial cultures, and try and get it sent out for PCR. This is not a diabetic foot infection. This is called mycetoma. It is a chronic granulomatous infection caused, there's actually two variants. There's something called eumycetoma, which is caused by fungi, and actinomycetoma caused by actinomyces. Primary risk factor is soil exposure. So in a patient who has this, who has no diabetes, no neuropathy, no obvious reason to have a foot ulcer that looks like this, you have to think about the mycetoma belt, which includes Mexico, Sudan, and India. Diagnosis, again, biopsy for histopathology, bacterial and fungal cultures. Another cutaneous syndrome would be disseminated pruritus. Most common would be scabies or lice or body lice. So, definitely I put this person on isolation if they have disseminated itching. But one thing to be aware of, just on the sort of tropical disease spectrum, would be this region here is endemic for onchocerciasis or river blindness. That's this area here. So that if someone is from this area, you can think of, and they have disseminated itching, you can think of onchocerciasis. Some chronic parasitic diseases that are worth being aware of. So this is just as a general measure. All recent migrants are recommended to get a single dose of albendazole as empiric treatment for soil-transmitted helminths. And it's often not done by anyone. But so if someone has also particularly unexplained anemia and GI symptoms, you can think of whipworm, which is hyperendemic in South America, and treat with albendazole for 3 days instead of just the one dose. Strongyloides has a worldwide distribution, basically everywhere. Even sometimes we get some domestic cases here, although mostly elsewhere. Strongyloides is the only soil-transmitted helminth that can complete its whole life cycle. So it can stay asymptomatic and latent for one's entire life and then reactivate as a deadly hyperinfection syndrome when someone is immunosuppressed. So you just screen with an IgG and you treat with ivermectin times 2 days, super easy, and you could potentially avoid some future deadly, life-threatening infection. The only caveat, ivermectin is 2 days of ivermectin has not hurt anyone except for people who happen to have a high burden of microfilariasis with loa at the same time. So this is the loa endemic region. It's really just this one part of Central Africa. That's where you have to avoid just empiric ivermectin because it can actually lead to cerebral edema. But that's if you have a strong GIGG that's positive in a patient from a loa from this narrow part of Central Africa, send them to me, and then I'll send them to a parasite expert. Chronic and then Chagas disease, another important chronic disease that unfortunately, is often asymptomatic. It usually has localized swelling. There's something called Rumania's sign, which is like a swollen eye. That's classic when the phlebotomine arthropod bites you. The thing about this is if you catch it in the latent phase, you can prevent cardiomyopathy. But once cardiomyopathy is present, you can't do anything about it. It doesn't help to treat it. So that's why screening with a one-time IgG and sending them to me if it's positive, so I can send them to the parasite expert or try to do it on my own, because it's a little bit complicated, but it's not so bad. I'd probably do that on my own. Okay, schistosomiasis, prevalent in tropical regions. It's another thing that we should just get an IgG and treat for. It's recommended specifically in sub-Saharan Africa, from people from sub-Saharan Africa, because while there is some schisto in Asia and in the Americas, it's not as common, but it can have late sequelae. Okay, I think I'm almost done. So obviously, if give everyone HIV, quantiferin, STI, and hepatitis B and C screening for all recent immigrants. It should happen at least once. And if we don't know about their childhood immunizations, you can get a measles and rubella IgG and give them their vaccinations. All patients should be screened for chronic hep B immunity. And then, like Gardasil and Shingrix are not so available worldwide. So that's another thing to offer immigrant populations to prevent them from having bad things. And then Tdap is people get tetanus back, but nobody remembers every 10-year a 10-year booster. Who can remember that? Okay, thank you very much. I'm sorry I went a little bit over.
It's okay. Thank you. Thank you very much. That was great.